feel free to comment on examples that you have, perhaps.
I think, again, it's another opportunity for students engaged in a learning experience to understand that scopes of practice, particularly for nurses and midwives, are oftentimes highly restrictive in other countries. That's not at all unusual to find that. And it is it's a difficult situation to be in because you may have been trained to, to be able to undertake procedures that they are not able to do. And then also by the same token, you'll also find that very frequently nurses and midwives and other care providers who have very expanded scopes of practice, not necessarily within their licensing or regulations, but simply because there's no one else around. And that presents a whole other set of ethical dilemmas that are very challenging as well. But again, when you look at it from a systems perspective, what do we do as individuals to support the modification and the change in that system? And obviously, I'm a representative of a professional association, so I believe strongly in the power of that body and the part that it can play in civil society, but in supporting our colleagues throughout the world who, can band together as a community and as a group and be able to modify or advocate for changes within their own legal system to permit them to do the kind of work that they are certainly fully capable of that aren't currently permitted to do. So that's another way for us to think about how can we work in terms of development that's sustainable.
One of the things I have fun watching when we take our students abroad, they're gone for a month, and intentionally we want them to be gone a number of weeks so they start to understand the culture. Landing in another country, the students have to do a windshield survey, the public health concept of just look around you, what services, what problems are there. So they do this initial assessment. Over the course of a month, I tend to see students move from evaluating this foreign destination from Seattle glasses, and as they begin to deal with air quality in the town and the transportation system, whether potable water is available and so forth, they start to see this other place from the perspective that's more similar to the residents of that place. So we hope that over a month they start to shift focus. In some of our situations, by the end of the month, the host will ask our students for their feedback. It's like they're the consultants, and it's amazing. Like hospital executives are pulling our students into the conference room, sitting them down at the table, and they'll say, be brutal with us. Tell us what you see that you don't like. And so we kind of coach them on being somewhat tactful. But they have offered some suggestions that have prompted the hospitals to ask us for things. So it's like, that's where we see the bridge, is when we're invited to give feedback. So one group of students went to Calcutta, and they noticed that a mother or possibly a father would come with a child for a corrective surgery, a cleft palate, but mom or dad or aunt didn't have a place to stay. And so rather than staying on the street, the students said, we have this system in the United States where some hospitals have a Ronald McDonald House, and the family who's responsible for being there for the small child in the hospital can stay in this Ronald McDonald House. All the students could do is give that idea. And by the next year when the students went back, the hospital in Calcutta had turned a spare room into lodging for 4 moms. And they were so proud to show our group. And that's where the faculty continuity is nice. The students, this was all new to them, but the faculty member could remember, oh yes, last year our students recommended housing for the mom who's staying in town for a few weeks and doesn't have a place to stay. So.
I guess I would say as an anthropologist, what they constantly are drilling into you is to look at scales and kind of this macro-micro connection. So look up first, study up, always look up. So I guess I would approach the systems question from, a few different ways. students or clinicians, volunteers who go and engage in this work abroad inevitably come back with a keener sense of the larger systems of inequality, of which we, I'm claiming myself as a white male who moves through this world, are inherently complicit, whether I like it or not. I benefit from larger systems and structures of inequality. I benefit from being able to go over there, elsewhere, to have the social capital of a global health experience and come back and have the 2-year requisites to get into the global health department at the University of Washington. So there's that system first and foremost. Second is working with, I think, local national healthcare systems, as Alan was saying. Health Alliance International has done a tremendous job of trying to making their mission to strengthen national healthcare systems, health systems, and have written an NGO code of conduct, which is just a set of 3, I think, guidelines, 3 or 4, of how not to contribute to the brain drain, how not to make uneven salaries to kind of steer people away from public sector work, and how to work to strengthen Ministry of Health systems in place. From my experience working in Nepal, there are a couple councils and boards that are set in place to register, for example, for the medical practitioners that come. The Social Welfare Council or the Nepal Medical Council are put in place, but because of political changes or load shedding, kind of this power outages that they have regularly throughout the year, electricity is not always working, so photocopying forms or getting through a traffic jam is often very difficult, and people forego register. And they often find themselves confronting these ethical dilemmas of, I haven't registered with the appropriate council, I'm not licensed to do this work, but here I am presented with this very pressing immediate health emergency, what should I do? Right? And forced to navigate those ethical dilemmas. But I think always registering and deferring to local institutions is a must. It has to be, otherwise it's an affront to the country's sovereignty that are hosting us. And hopefully that's part of the buzzwords of creating transparency and reciprocity. It involves respecting your institutions enough to, even if they're not perfect, even if they are flawed, to work with them. And then I guess the last system I would focus on, to go back to my medical anthropology, is the different plural medical systems. Working with local leaders and religious practitioners and faith healers, for example. At these health camps we used to organize, there were shamans and other traditional faith healers always there. And people would say, oh, they're just here to get medicine so they can sell, and then try and look powerful. That's actually not true. They were often there because people who would present at these health camps would take the medicine and then go over to the local faith healer, who would then divine over it to see which would be auspicious or which one would not necessarily be useful, or which was an inauspicious color. They would blow mantras over it. We had this one incident where doctors were trying to get all the children to take albendazole, this very common worm tablet, which is tremendously beneficial. One take it once every 6 months, but it was an inauspicious color. Something as simple as that, which is why this idea of cultural competency, which is a really great word, often belies the fact that maybe instead of competency, which, especially in medical school curriculum where you are tested on other competencies, it's still this idea that, well, if I can just be competent in someone's culture, I can understand it or get around it or overcome it to do my job of effectively delivering medical care. And maybe, as I think everyone here said, cultural humility is perhaps a little bit more the phrase, knowing that perhaps you don't know enough to understand the entire plural medical system, and trying to work with local healers, healthcare providers, because they are first line of the public health system. We're talking about where people go in terms of their patterns of resort. But regardless of what they may say, I think we have to work with these larger plural medical systems.
Okay, great. So this is the last of our prepared questions, and then we'll open it up to the audience and also bring Rebecca up here to have a broader discussion as well. But I wanted to ask you, Suzanne, about the importance of partnerships. And I know Rebecca really emphasized the importance of partnerships in the work that she does. And, whoops, all right. We've broken it now. So you work with the Survive and Thrive project, which partners with USAID, other private partners and civil society organizations to reduce preventable maternal and child deaths in developing countries. Can you talk about how you see these partnerships promoting the sustainability of the program, and also, since we've been talking about the importance of partnering with public institutions, whether and how the program partners with public institutions as well?
Thank you very much, and thank you to Jennifer and Karen for moderating, and thank you to the Dean for hosting this, and to Karen for her inspiring work, and to the panelists who joined me today. So the Survive and Thrive Global Development Alliance is an initiative that was started by USAID. It's a public-private partnership, and the vast caverns of AID, there's in all the different departments, there are actually a number of different global development alliances in different sectors, but this is one in the health sector. The unique feature of this GPA is that there is USAID, Japan, which is a large maternal child health NGO, Johnson & Johnson, Laerdal Global Health, and then 3 of the professional associations in the U.S. that are primarily involved with maternal child health. So American College of Nurse Midwives, American Academy of Pediatrics, and the American College of Obstetricians and Gynecologists. And what we found, this is actually, it's a relatively new initiative. We just signed the memorandum of understanding 10 months ago, and it's kind of a large amorphous beast that is taking shape as we speak. And so at this point, we're still beginning to give form to some of the ideas that launched the initiative. But the objectives of the initiative are to promote the implementation of high-quality, evidence-based clinical interventions within the host countries, clinical interventions that we know save mothers and children's lives. The second objective is to strengthen professional associations within the country so that they can take their rightful place within civil society by advocating for both the members of their society and ultimately the people that they serve, and to also be able to take their place at the table with the government of the country, the health sector of the country, and help to shape and advocate for public policy, for health policy. The unique feature of this is that the professional associations are involved, and what we've seen is that that really is a very compelling aspect, and what has made a number of countries approach us to ask that we participate in their country's health development programs. So in terms of sustainability, I think really that is where the sustainability of this particular global development alliance will lie, in the relationships and the capacity building and the kind of expansion of the scope and the nature of what the professional associations do within the host country. Professional associations in a number of different countries around the world oftentimes function more as trade unions as opposed to anything else. And so the concept of a professional association providing guidance in terms of standards of care, promoting excellence in provision of care, excellence in educational standards, all of those things are relatively new concepts with which we hope to be able to build more understanding and more development.
So I think we'd like to invite Rebecca here to join us and open the floor to questions from the audience. So as I said before, if you would like to just come to one of the microphones and ask your question, you're welcome to do that. Or if you've written it on an index card, we have a representative who will collect this right now. Questions? I can.
I have a question that I could get the
question. So, Med25, one of the many partnerships that are important on the ground that a number of people up here were talking about was the partnership with the government. So the local government in the community. How kind of Kenya government healthcare services are distributed is based on the level of hospital. So Vita is actually a district hospital, but it has just recently become a district hospital. So there are a number of services that are not provided there or are supposed to be provided there but have not been implemented yet. And that's something that hopefully in the future they'll be working towards implementing those services. But unfortunately right now they're not there. Another really important point that someone brought up was when you were talking about Health Alliance International, David, and talking about kind of making sure that you're being competitive with the government facilities and not kind of pulling them towards the nonprofit sector. That's another problem. Kenya is actually the CDC headquarters for all of Africa in Kisumu. And there are a number of different nonprofit organizations, and there's kind of a pull towards larger nonprofit organizations like PATH, the CDC, USAID, FACES, a number of nonprofits that are working in the area that do provide much higher salaries because they can. And so that makes it really hard to get people not only in the government facilities in rural communities, but also for small nonprofit organizations like ourselves. We always try to stay competitive and make sure that we are providing everything that we can, but trying to keep it at a similar level and keeping those services in the rural communities so that people don't have to drive 3 hours to the main city because transportation alone, they aren't able to afford care then. So partnership with the government is crucial, but making sure that we're working with them and then bringing them kind of along with the work that we're doing and making sure that that we're partnering with them and getting services from them, things that are provided to the government from large NGOs. For example, malaria care in Kenya is free. They oftentimes don't have the systems in place to get the right medications at the time, so they don't have the medication for free. So they'll diagnose you and say that you have malaria, and now you have to go pay 300 shillings, which is about $4 at a local pharmacy to pick it up, even though it's supposed to be a free service. So that's something Med25 makes sure that we offer for free, but then what are ways that we can continue to support each other and strengthen each other's systems.
So we have a question from the audience. For any willing respondent, what can universities, in particular, in your opinions, contribute to closing the global healthcare divide? So what is the unique sort of place you think of the U.S. or perhaps international universities are working together in addressing some of these global healthcare problems that we've talked about tonight?
I'm thinking about the global divide. Education really is a key component of our trips abroad, and there's a real openness anywhere we go for our host sites to learn from Americans. Somehow that word is out there, that word into research and so forth. So it has continually surprised me how open nurses, doctors, executives, university professors want to learn from us when we go abroad, and they're asking students who are in their senior year. We try to share what information we can. An example last year was in Kazakhstan. The medical officer for this hospital we were at was doing one of these debriefings at the end of the student's month-long experience, and he started to share with us that one of his big concerns was to understand how Americans did quality assurance, quality improvement systems. And so I gave him some examples of how we might track on a problem, post data at the hospital, have the whole staff get excited about downward trends of adverse effects, and people try to figure out solutions. And he liked the conversation, but he said, "Can you send me anything?" And so I came home, I found a document on quality improvement systems from the Joint Commission and mailed it back to Kazakhstan. So it might seem like a drop in the bucket, but it was like probably more effective because this medical director asked for it, and we were able to understand his specific request. He made it specific enough that we could do something about it. We could paper a book and post it to get it to him. Went back the next year, and he expressed his appreciation that it had arrived, and he's learning from it.
With the example of the Ivory Coast or Mozambique, it's universities are viewed as very prestigious institutions. So for institution in Cote d'Ivoire to be able to collaborate with a university, they really see it as a lasting relationship where you can really have exchange of data, like Carl was saying, exchange of information. And sometimes we may have some information here that people don't have to make it available, and also get information that people have, and really discuss how you view those data. When we work with some of our colleagues in the Ivory Coast and on a study, we make sure that we design it together. So it's complicated, but we make sure that we are on Skype. And so that we can really discuss those. So the database is available to both sides, them and us here, so that we're both connected on Skype. So as we discuss it, they'll also have it projected on the computer so they can see we're talking about the same variable, the same indicators, and hearing from them what do they think that, how they're interpreting the data. And I have found it very, very enriching. And they have also found it very, very enriching as well, because they feel like we're exchanging academic ideas and ideology, and it has gone really well. It's slow, because I could just get up and say, okay, all right, I think I understand, this is how we need to choose those variables, and this is how we need to code them, and then probably in a few hours I can get it done. But to work with my colleagues there means that it takes, a day to plan it. Okay, when is a good time? Okay, over there, the 8-hour difference, so that means we got to set it up so that's not too early my time, it's not too late their time. Then you get on Skype, and then there's no power at their end. So it's like, okay, we can't do it now, or we have to reschedule. But when we do all that, you just get frustrated. You take a picture of the design, you send it by phone so somebody has it there. By the time you finish, you're exhausted, but you feel great because you feel like it was really teamwork. It was partnering. So we have found people to really appreciate that kind of exchange with the university setting.
Yeah, I guess just in a similar vein of exchange, I would say global health departments are growing in universities around the country. There were any number of years ago. A lot. Is it? Sorry. Okay. I would say maybe global health departments, universities in general. Again, not to say that we should stop going ourselves or stop sending people from our universities abroad, but maybe part of this reciprocity is having some of the money to bring more people from the countries where we're going to help here to learn to develop healthcare workers, because ultimately they're the ones who are going to go back and try and bolster their existing public healthcare systems. And I know of one NGO. It's an NGO. It's not a university, so I'm off topic. But what they do is bring mostly women, female community health volunteers over here to learn just basic diagnostics for very basic stuff. It's a 12-week course, and then they go back, which is amazing because many of them have never left their district, let alone come to the United States to participate in some of this important skills set training. But also I'm thinking of the University of Washington, which brings folks from Ministry of Health over to improve monitoring evaluation skills, lab statistics, epidemiology, and then they go back to their ministries and incredibly useful and can teach these skills to others. You can't escape the trappings of power and inequalities, because then these folks get more social capital, and you do introduce new inequalities in this way, but I think something like that, more reciprocity in terms of bringing folks over here.
would be good.
I think this is not anything new, but just the ability to identify a site where there will be a relationship and then sustained continual involvement that really represents true professional interchange is just one of the biggest assets that universities can bring. And that coupled with research. I have not met any colleague anywhere in the developing world that doesn't yearn to do research. And for any number of reasons. I mean, some of it is professional, personal professional reasons. Some of it is because they understand the power of data, but don't know how to they don't know how to harness that power. And it really feels like it's a key to the Magic Kingdom, that if we can somehow be able to help build that capacity, it would mean a lot in terms of strengthening the infrastructure.
So the question I have here is, some are of the perspective that we need to focus on our local health problems and issues before even beginning to reach out globally. What would be your response to this argument? Open it up to anybody who wants to tackle that.
Our thinking is that if we take students abroad, they'll be better equipped to come back and deal with health disparity needs here. So often they are tied to socioeconomic, cultural groups. And if our students are more comfortable dealing with someone through an interpreter because there's a language barrier, different cultural background, they'll just be better able to do that work cross-culturally. Periodically, I get the question, like, why do you invest in taking students abroad? And it's hard for students and even faculty sometimes to just hit the nail on the head. It's hard for them to verbalize. One time I asked an emergency room nurse graduate for our program that just general question, what did you get out of doing this? And she basically said, I don't know how to answer that question, but let me tell you a story. This is the disparity piece. She said, was in an emergency room, and the patient was a mom presenting in labor. Culturally, it was unacceptable to have a male healthcare provider for this mom because of the country from which this family came. And husband was there insisting that no male physician was going to take care of mom ready for delivering a baby. And they tried multiple healthcare practitioners, multiple comments, nothing was working. And so finally our graduate said, I simply go into the room and talk with this couple. And our graduate went in and simply began talking about her cross-cultural experience when she was at Northwest University the month that she was gone, what she saw, what she did. I think it was the same country as this couple was from. And at the end of like a 15-minute description of her trip, the husband said, I'll let the male doctor see my wife. And so it's, how do you put that into an equation? Maybe it's the rapport that you build with patients because you can understand a little more where they're coming from.
I would say do both. And the other, I just feel like because we are from the U.S., we have a very unique both burden and responsibility. We come from obviously the most privileged nation on earth, and I think it's extraordinarily important that we understand that because most people in this country do not. And once we leave that bubble, our lives are forever transformed. And I think that it's particularly key for those of us who come from this country.
Just to kind of add on to that real quick, I think not only about doing both and getting that exposure to another country, but until you know what it's like to go into another community and not speak a language and have to try and seek healthcare, you don't truly understand what it's like for patients here. And so kind of getting outside of your own comfort zone and having to navigate a system, you have a new respect for what patients go through every day to navigate their entire world here, let alone seeking healthcare. I think also some people have traveled abroad and then come back and worked with different refugee communities. For example, going over and volunteering in Somalia, then you have a new set of skills to help work within the community here. On a personal note, my husband is actually from Kenya, and he works here as a medical interpreter, and he says that that's just made his work in Kenya that much stronger, to be able to come here and interpret and to be kind of a bridge between two cultures while understanding in a broad culture and also being able to provide those services here. So you don't have to be from that another country, but to be able to understand the struggles that they face. I think you have a new respect or a new view for how difficult it can be for some of our patients in the Seattle area.
I would add to this. I guess I'm going to have to do this, otherwise I wouldn't feel good about it if I didn't. I'm going to have to channel my advisor, who many of you probably sitting here will know, Stephen Bezruchka, is a doctor who worked in the ER for many years here in Seattle, but also has worked in Nepal, which is how he became somebody I sought out. But he, if you don't know who Stephen Bezruchka is, Google his name, watch his TEDx Radio talk. He has become obsessed with the idea of population health and why in the United States, where we spend more than half the world's money on healthcare, our health status measured in, you can pick an indicator, but life expectancy, maternal mortality, the chances of living to 45 if you are 16 based on certain demographic areas in the United States is not what it should be. It's slowly decreased in what he calls the health Olympics over the past several decades, and he's become really wrapped up in this question: populations to be healthy. What is population health about? And as a medical practitioner, he's in this very privileged position to say, well, I don't necessarily believe it is medicine that causes people to be healthy. It's about inequality, sharing and caring relationships. So in that sense, I think he's really colored my perceptions around, if we don't know necessarily what causes health status here at home, maybe we are following around trying to figure out how to go abroad telling people how to improve their health status. Again, this is population health level stuff. I'm not talking about individual instances and smaller scale stuff in communities. Undoubtedly, there's a role for medicine improving health and wellness. And then the second thing I'd say is, bringing home global health starts right here at home. The King County Public Health System has just started a new joint program called Global to Local, working with recently